Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. Today, we are at episode 131. And I hope everyone is safe, staying at home as much as possible. Of course, protecting yourself as much as you can. As most of you know, I've been dealing with telehealth since March 1st, and it seems to be the only thing anybody wants to talk about. And I really didn't want to do another telehealth podcast. But I mean everyone, clients, non-clients, AAPC, and AHIMA chapters that I've been speaking at, social media boards, LinkedIn, Instagram, you name it, people are finding me. So I've been teaching, presenting, training, you name it, just living telehealth. And I was so happy the other day, somebody asked me a cardiology question or an orthopedic spine question. But for the better part of 2 months now, as you know, this has been kind of our new normal when it comes to how can we generate revenue with our existing patients if they can't come into the office. So I think it's important today because everything keeps changing. I actually got a direct message on LinkedIn today from a member who listened to a PACOM podcast, so the Professional Association of Healthcare Office Managers, not a podcast, I'm sorry, a webinar that I did for them in March. Actually, it was mid-March, right when all of this hit. And they're like, can you please talk to us? Can you please talk to us? And I said, sure. So it was actually around the March 13th time. Well, she said a question today. She asked me through direct message. And I noticed that her question was very dated. She said, I loved your webinar. Thank you for speaking for our chapter, blah, blah, blah. And I was like, wait a minute. You're asking me a question that hasn't been valid for at least 2 weeks. So what's interesting, and this is where everybody really needs to understand, telehealth keeps getting updated. And again, if you need this in any kind of PowerPoint or educational format, I'm going to send you back to my website. If you need to teach your physicians and you need things in writing, my website at terryfletcher.net, I have an on-demand webinar, and it's for telehealth, and I update it every 48 hours. So what's up there now is something that you would get the update, and you'd have to purchase that, though. What I'm going to do is basically have a conversation with you just to give you basically the can and cannots of telehealth visits as it appears and today. So today is April 21st. And so today is really what we're going to focus on. And just so you know, this can be dated if you're listening to this in May or June or July, because obviously then there's going to be something we're going to have to talk about how do we get back to our old normal if that's where they're headed. But anyway, we just want to really bring you some of this information that has been coming out, a lot of falsehoods, a lot of information that just is really, I guess, misleading is the best way to kind of put it out there, or misinterpreted. And also then we get the states. Like California did something that doesn't make me happy. They take it upon themselves to say, okay, well, this is what the governor's executive order says, and everybody should do this now. But they need to not forget that Medicare is at the direction of the federal government. That's CMS, and things get confused and misinterpreted and falsely posted again when you basically say, well, California said to do this, or Texas said to do this, or Minnesota said to do this, which are all different, by the way. And so that's what you should do for everybody. There's not a one size fits all in telehealth. As you know, for those of you that are my clients, I've sent you a commercial grid that I keep up try to keep up every couple of days. But it basically says, okay, United Healthcare is doing this, Cigna's doing this, Aetna's doing this. And so it's tough to keep that up because every payer, other than Medicare, wants a different modifier, wants a different place of service, will only allow certain things to be done. And so it's really tough when it comes to consistency. I'm against the single payer system. I think that it would be bad for the country, but I can see where this is making an argument for it because nobody is on the same page. So you want to have a little bit of consistency here, and it's kind of crazy. I tell you, some days I really don't like social media. Some days it just causes more trouble than it's worth. And also people are starting to get angry now because they're bored. And so when you get bored, you start to look at things that you should just put your phone down and say, I need to take a break from it. I had to do that the other day because I am not shy at all about my political affiliation. I'm just not. That's just not who I am, and I'm going to stick by what I believe in. But when the opposing side tends to be a little bit more hateful, there's just some days that you just have to say, enough already. Right now, it's a bad optic for everybody, both sides. So we just want to give you as much information as I can, making sure that you are accurate, you're up to date, without going into the whole PowerPoint presentation. So I'm going to do it as what you can do versus what you can't do. I also update my blog on my website too. So if you want to read some quick things on there, feel free to check that out. Some good information. The last one I did was telehealth billing coding for non-video phone calls. And I'll cover some of that on here today, but it's just some of the things that have been put out there is just starting to drive me crazy. So I wanted to just say, okay, can we do this again? Actually had a very good client of mine, been client for probably 11, 12 years. And she asked me the same thing that I've been sending out all week. I heard this was a change and we can now do this. I'm like, no, you can't do that. So let's get on the same page as far as the can and cannots when it comes to telehealth. But first, the Codecast podcast is brought to you today by Murad Hydrating Water Gel, the face moisturizer that features a unique blend of 5 minerals, 5 vitamins, and 5 peptides. Helps strengthen the skin's barrier in as little as 30 minutes to prevent water loss while refreshing and smoothing skin. Murad.com. Turn on brighter skin. Okay, so here we are. So a couple of things, somebody's asked me before, but let me just clarify. So when billing office visit codes, and we are talking about 99201 new patient to 99205 new patient, all the way to 99212 to 99215 established patient. So yes, you can bill those as long as there is, again, two-way interactive video communication, such as a FaceTime call or a Skype call or something that is, Microsoft Duo or something to that effect. You have to make sure that the physician and the patient can hear each other and see each other and have a conversation. So this is where it is not changed. Medicare is getting a lot of heat about this, and they said, there's certain older patients that can't figure out their video system. I'm finding that patients don't want to. They're saying, well, we don't want to do the video because then I'll have a copay. And on the telephone calls, there's not necessarily a copay. Well, that's not true. The only thing that doesn't have a copay is if your services are related to COVID. And if they're not, then you have a copay and deductible potentially. Now, your physician can determine or decide not to charge it, but you still have that. So again, when you're billing office visit codes, just as if they were coming in the office, and you need to really hear me here, be clear, 99201 to 215, so new and established patients, you can bill that as long as you have two-way interactive video communication. And here are the questions. So here's the can and the cannots. Can we bill it if the patient turned off their video but the physician can see them? No. I'm going to say that snippy. No. If you cannot have a two-way interactive conversation, then no, you can't. Okay. How do we bill it if the patient started as an audio-video communication and the video portion stopped connection after 5 minutes due to weather, and we could not get it back up? We continued with the audio portion only of the telehealth visit. Can we code for an office visit in this case? No. So here is the thing that you have to really keep in mind. In the time of this crisis, you need to call upon some common sense here. If the physician's discussion is interrupted and you move on from a visual to a telephone call, that needs to be documented, and the coder should bill for the service that was rendered. It is no longer considered an audio-visual. If the physician did an E&M all in the audio-visual portion of the Skype encounter, you have more of a case for billing a telehealth 99212, 213, 214, etc. But if it was truly just a phone call and your time, now you have to time it as well, then you're back to the codes of 99441 to 99443 for your provider. So try not to get around the system. I'm seeing this more and more and more, and it's seriously frustrating me because I don't want to see this much non-compliance. I'm not going to use the fraud word. I don't like the F word, but I'm telling you, it's really starting to rear its ugly head. And I know financial distress does that, but you have to be very, very careful not to buy into it. So another question has come up about the virtual check-in. And what does that mean? Well, there's been, and I'm going to give you a can or cannot. So if a patient calls, and it has to be patient initiated, so they're calling your office and they say, can I speak to the nurse practitioner or PA? And they get on the phone, and it could be a doctor, but let's just say they're calling for mid-level. And they're saying, I'm having a really tough time. I feel like I've got this itchy rash and everything. And can I get some ointment or get something to maybe prescription Benadryl or something that'll help me with that? And they're talking to your mid-level provider, and they're saying, have you come in the last 7 days for something similar? No. And then they go ahead and send a script in for whatever it is that they need. And then they don't say to come back into the office. Just give us a call if there's a problem. That's a virtual check-in. And now you get to do it for a new or established patient. So that is a can. What you cannot do it for is if a patient came in for an actual visit. Let's say that they were concerned, potential COVID. They came in on one day and they had shortness of breath and coughing. Doctor did a test and determined that's not what it was, that it was the beginning of just maybe an upper respiratory mild asthma issue. And so they basically said, okay, go ahead and go and we'll see you at another time. 5 days later, that patient calls and says, I'm still coughing. What should I do? And the doctor says, okay, we're going to need to get you to come in and we're going to do it as safe distance as we can, and then schedules the patient for a visit. You can't bill that virtual check-in because they were seen not only within 7 days from the last visit, but also they're coming in for the next available. So that is a cannot. You cannot do that. And I'm seeing these virtual check-ins billed for everybody. And this is something that's being pushed, $14 visit, $14.40, but it's pushed because, and you've heard this word, I'm sure, on press conferences, it's to mitigate should there be a visit. And it's to determine, should there be a visit or should the patient just get something quick and stay at home? So that's what the virtual check-in is for, and be clear on that. Now, here's another can or cannot for telephone visits even. So I've had somebody ask me, so can we call patients now and give them their test results over the phone and bill an office visit? Well, would you do that normally in the normal course of your practice if there was just a regular normal test result? No. You may call them, but would you charge for it or bill for it? No, you would not. So that's a cannot. If it is a normal test result, either send them to the patient portal or let patients know that that's available, or basically call them like you always have, and there's no charge for that. Now I'm seeing that the doctors are directing their medical assistant staff, LVNs and RNs, to use the ancillary staff phone call codes 98966 and 98968 for simple non-medically necessary phone calls for test results that are normal. Now, let's just say that you have a patient where it is an abnormal result and there needs to be a phone conversation and there's no video. And so that would be the time to use, again, provider phone call codes 99441 to 99443 based on time. You still have to get verbal consent. And then if it was a qualified provider, able to use the other phone calls like a social service provider or a psychologist or anybody that's not MD or DO, then those are the providers that get to use the other codes 98966 to 98968. Okay, also remember, and here's another can or cannot. So our phone calls telehealth, not under the current definition, no. And so they would not need a modifier. So phone call only, no video, does not need a modifier 95. Remember, Medicare changed that in April, and so basically on March 30th, and they said that a 95 modifier for telehealth visits, meaning the office visit codes when they are used from an audio-visual visit, need the 95 modifier, not phone calls. They're telemedicine, they're not telehealth, and the phone call code itself is a descriptor where you don't need to then double modify it, if you will, with a 95 modifier. Another do and don't, or I should say a can or cannot, is the CS modifier. So C is in cat, S is in Sam. So Tara, here this modifier comes out and we're supposed to put it on everything so that a patient can get, so we can get 100% and the patient doesn't have to pay their out of pocket. Again, that's a cannot. What the CS modifier does is it identifies testing, lab work, office visits, anything that was done to determine the patient had or did not have COVID based on their symptomatology when they come in. So if it's related to COVID-19, then yes, you need to add the CS modifier. And now what happens is that Medicare will reimburse at the allowable. So you're saying you're not going to charge them their out of pocket. Do not do this for non-COVID related services because it will be denied and get called back. So there's pretty much descriptors when it comes to that direction they gave on the, when CMS posted the direction on the ICD-10. And again, if you're a Coding Corner client, I sent out that information. So you can have that again if you want to join the service. So I try to give you as much information as I can, but for those of you that are trying to get a lot of things for free, that's the podcast. But I do a lot of research and I get a lot of information in my inbox before you probably even get it. And I just want to make sure you have it, but that does cost time and money. So that's why there is a service for that. So this next one, I'm going to relate it to telehealth, but really just the pandemic and what's going on, because this was a question that came up and I'm going to make it my coding question. But today, since I'm answering or responding to some coding questions with regard to telehealth, it's really a management question. It has to do with the money you got on 410 and 413. Many providers got a lump sum dropped into their bank account saying that this is to be used for any kind of COVID related losses and expenses. And then luckily HHS came out and said, well, we're backing up the train on that a little bit. If you had any losses, it doesn't necessarily have to be COVID diagnosis related, but because of the pandemic, you can now keep that money as long as it's spent on services, or I should say expenses that you've incurred because of the downward revenue or because the pandemic really has stopped a lot of elective cases and you've had to cover some payroll services, things like that. Make sure, I've had some practices that they're like, how would you really deal with this? And I'm actually having my clients put it in a separate account and then make sure that they've got a good spreadsheet listing of their expenses that they're applying it to, just in case that anybody's trying to get it back. Remember, everybody, we are in an election year and who knows what's going to happen. If anybody realizes that now the country is so far into debt that they've got to figure a way to get it out of there. So, or at least try to pay for some of these things. So anyway, these $1 trillion stimulus drops in your account. It looks like you can keep it as long as it's a CARES Act, as long as you can show that there was a relationship between the losses and the pandemic. And that shouldn't be really hard to do. So just keep track of it and you'll be okay. And you want to make sure that you're tracking it in a calendar order as well. Another question has come up, and I don't know if this is a can or cannot, but I should probably just call this an open forum on what's happening right now and some of the questions that have come up for me. But a question came up as far as the 2021 E&M update, and somebody had said, oh, that's going to be pushed with all that's going on. Actually, it isn't. So something that came out in the update from Medicare, the CMS update on March 30th, was that when they were talking about documented documenting services. They reference the 2021 E&M guidelines and said if you want to use those time thresholds and use the documentation, since obviously doing a complete exam is not going to be possible via telehealth, and a history is going to be limited because it's just going to be asking questions like on our review systems, and so it's not really touching the patient. It's really more of a discussion, if you will. And so, but they want you to keep the medical decision making as it stands now. They don't want you to go there. Or you can time the visit. But they referenced back to the 2021 new guidelines and said if you want to go there for telehealth, you can. So that tells me that they're not going to delay it. If they're already saying that it's out there and you can use it, they're not going to delay it. So just a reminder, we do have some modules coming up for that. We did push them to the fall. So you'll see those available. We've already had one, and then I present another one in August, September, and October. And then that way you'll be able to, because it's a 4-part series, you will be able to present it to your physicians come November. And you don't want to give it to them really much earlier, because as soon as you start training physicians to do something, they want to do it yesterday. And so when you tell them that things are going to really change to their favor, and we're also getting some major increases in E&M services, then you want to wait to the, I don't want to say the last possible minute, but to the point where you're not going to have to say, I told you this wasn't until 2021. But you just want to make sure that you are methodically getting trained on it. And so make sure you're taking a look at the website for the different parts to that. And for those of you that have signed up and joined for that, hopefully you're enjoying the part that you've listened to and looking forward to the next 3 in the series. But it's a really good series, and just lets you know from beginning to end how to get it implemented, what's changing, how to audit it, and then examples of documentation. So that should help you as well. There are a lot of changes, so please don't push that to the side. Now, the last thing I wanted to kind of talk about today is what can you do with some of this downtime? So I know a lot of you have had to scale back your hours. I know one of my biggest clients, they have their staff working only 5 hours a day in some instances. This is the time, because it's slowed so much with office visits and procedures and, things that are not considered to be emergent in nature, that you may want to really work your accounts. Start working your ARs, really start working some of those past balances. Show how valuable you are to the practice by getting some of that old money in. I know that's what I would expect my staff to do. I know I have some of my contract staff working on that as well for some of my clients. And so it's important to make sure that you're not just saying, well, my job right now is stalled. Find something to get yourself motivated to make sure that the practice can stay viable so that you can go back to work when they open up some of the areas, which I hear is starting to slowly happen. So just make sure that you're always looking for that next opportunity as far as making yourself as valuable as possible. One thing I have going on today is later on I'm teaching and I mentioned it before, a job market healthcare workshop for the women in healthcare administrators. And one of the things that I'm talking about is, risk manager, telehealth specialist, but also an AR specialist, because I've noticed that a lot of practices have kind of let that go a little bit. They're saying with their volume, they can't really work it, but volumes are down. Work your ARs, get some of that old money in, because there's going to be payers saying, hey, we've been paying out too much on telehealth, so now we just want to, we're going to delay some things. Don't do that. Make sure you are really saying, take the initiative. You're saying, give me some AR and I'll work on that because I want hours. Of course, you need to get paid for that. So hopefully you're getting hours for that and being able to show how valuable you are. But your physician will appreciate that, getting that all in. So our coding question was brought to you today by Advanced MD, cloud software for independent medical practices that delivers industry-leading patient outcomes and financial performances. AdvancedMD.com. So I wanted to end this week with some good news. Yay. I don't know if you find it good news, but I do. Starbucks announced they're opening their stores. So not just the drive-thrus, which is like a 30-minute wait, kill me now. But on May 4th, they said that they're going to start opening stores for mobile and to-go orders and minimal lobby attending people. So I think there's a light at the end of the tunnel for me. I mean, as soon as you see that Starbucks is starting to open, you just know, because they're worldwide, you just just know there's got to be some kind of light there. So I realize sometimes it's just the little things that matter. So hopefully you found a couple of those little things. You're having fun doing puzzles. You're catching up on some things you haven't been able to do at home. We actually planted an herb garden. I don't do that. So that was kind of interesting. But just really, trying to do something different. So everyone on this Terry Tuesday, make it a great day and a great week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.